Thank you, Sherry. Hello, Scott. Hello, Dr. Tringone, and welcome to everybody. Good day, whatever time it might be that you're joining us today. I'm Dr. Seth Grossman. We won't take a lot of time with introductions as they've already been done. For CE purposes, we will give our basic disclosures, and that is that both of us are royalty recipients for our respective tests that we've worked on under the Milan camp. And we are paid consultants for various projects for Pearson and for the Milan Personality Group. We are really happy to be presenting this particular topic and topics like it coming up in the future that are really trying to connect the dots between who a person is and what it is that they're presenting with clinically. This is a perspective that's always been at the heart of the Milan inventories, and one that, with changes starting with the DSM-5 and really sort of the trade winds of the field right now, may unintentionally get lost in the idea that personality is really kind of becoming more interwoven and, I guess, less in the spotlight than it has been in the past, with moving from a multi-axial system to a single axis, and with some of the newer models that have come up that really are trying to put personality on the same plane as others. What we contend, and what we're going to be talking about in a major way today, is that who the person is going to play a major role in terms of how it is that you take perhaps some of your standard interventions for depression and modify them to really be able to see what's going to be most effective in what area. And Dr. Tringone and I are coming from the same school of thought, but we tend to emphasize slightly different areas of that endeavor. So you'll kind of get the demonstration from both of us about the fuller picture of what we do. So that in mind, for first couple of minutes or so, I'm turning over to Dr. Tringone to add anything to what I just said, and then we'll move on to objectives and start the substantive part.
That was a nice introduction, Seth. I appreciate that. And if we can move on to the next slide, because you and I, as always, have an ambitious agenda, and we're going to try and get through as much of this as we can. So let's just take a quick peek over at the learning objectives, and we'll deal with the core tenets of Dr. Milan's theory, which is going to be about polarities and domains. And when we identify people according to the model and our instruments, we really want that to be able to translate into what are the therapeutic applications. Really important in terms of where I like to work, especially with children and adolescents, is to identify what some of these early patterns are that have been developing, and to identify what are the possible personality factors that may perpetuate the pattern that's already in operation. I also like to work in terms of parenting styles and the interactions between a child or adolescent's developing personality and the ways in which they're interacting and working with their parents, who have different mindsets and different ideas of how to parent and so forth. And what we would like to do is to make sure that we are identifying that for us, as it has always been in all the years that I had the opportunity to work with Dr. Milan and now with Seth, that we see it, that whether we are dealing with ADHD, as Seth and I had addressed in a recent lunch and learn with the authors, or with depression for today, that it really is important to understand, while those are important clinical constructs for us, that who is the person that is dealing with ADHD, dealing with depression, because it makes such a difference in terms of what our outcomes can be while we're working with them. We'll move on to the next one, sir. In all my years, this is one of my favorite slides, but I will go through it quickly for you. As I said, we do have an ambitious agenda. Dr. Milan created a clinical science, usually referred to as clinical personology, and he outlined that there were 4 particular components. The first one, and we were very fortunate to have exposure to it, is theory, and the idea that a good theory guides us. It helps organize and understand our observations. Dr. Milan's theory evolved from a biosocial learning model to an evolutionary one, and yet both of the models rely on the same three foundational polarities. Taxonomy is the second component. Dr. Milan created a taxonomy consisting of 8 clinical domains, and they represent different data levels and actually different schools of thought, which makes Dr. Milan's theory very comprehensive and integrative. For the MCMI-4, there are 15 personality disorders that his theory outlines, and according to various polarity configurations, have specific defining features within each domain. So the taxonomy component of the system represents his effort to align the field of clinical personology with the hard sciences. Instrumentation is the third component and the one that we are most recognized for. It represents the operationalization of Dr. Milan's theory and the constructs that are derived from it. I mentioned just a moment ago, there are 15 personality pattern scales on the MCMI-4, and there are 11 personality pattern scales on the Mackey-2, and those personality scales represent prototypes when there are single scale elevations. However, in the majority of cases, there will be at least 2 personality scale elevations, which represent personality subtypes. There are scores of personality subtypes, and if you are looking for some summer reading, the Disorders of Personality 3 would be quite a book for you to tackle. It does outline, though, all of the personality subtypes. And finally, the last part is going to be intervention. And as clinicians, we take in all of this information, and then we want to make a difference in somebody's life. And the way that we look at it will be to modify these polarities from component number 1, which are usually formulated to represent imbalances or conflicts. We identify and counter self-perpetuating tendencies. We are continually setting up to have replications of what our previous experiences were. And sometimes those are contributing to the overall distress that somebody might be experiencing. So the idea is, can we identify what are some of the things that somebody might be able to change, whether it is their thoughts or their actions in particular, especially from those CBT and DBT models. And finally, because of the different schools of thought represented by the taxonomy component represented by those 8 domains, each of the personality types or disorders has clinical features or traits, and they can be addressed within domain-oriented techniques, whether that's cognitive behavioral therapy, object relations theory, working from the self-psychology model, interpersonal relations, etc. That was a quick outline of one of my favorite slides. What is next, Seth?
Okay, well, next up, we're going to really start to tap into this area of theory and give you some overview in terms of how it is that a theory might be able to get you in close proximity to what a person's experience and their experience of themselves might be. So by necessity, this is going to be somewhat superficial in terms of how it is that we describe the theory. It's really kind of giving you the building blocks. And building blocks is a good word for that. If you're thinking in terms of the MCMI or the Mackey or any of the instruments like Robert had mentioned, each of those scales are prototypes, and they are all built out of what I'm going to cover next. And where the real power of it comes in to get as close to the person's experience as possible is when you combine those, understanding the theory elements and being able to say, what would that mean in terms of how do I relate to this person and what interventions I might use? So again, this is somewhat of an overview. Pearson has a number of resources in and around the test sales pages that, if you look under those resources, you'll see some of the webinars. And they go a bit more into detail than what we're going to do today as far as theory. But to kind of give you the overview and then bring that back over into the question of how do we deal with depression in this person or that person, that's what we'll be doing here. So Robert had mentioned, and now we'll start to look at this. There are three basic motivations that Dr. Milan posited that human beings in their personalities and in their self-expressions and in their inner experience are paralleled with the natural world and specifically the living world. That there are different kinds of skills, different kinds of behaviors, different kinds of positionings, if you're talking about the wider stance of living organisms, that allow a person to be able to survive, thrive, and then keep up that species. For most of the organisms, they have a rather fixed way of doing these things, and they might have a particular strategy that works for them most of the time. For human beings, you can imagine if you use the same strategy over and over and over again, or you become much more fixated in the way you do things, or much more stuck in the way that you perceive things, you're going to have more difficulties within personality that will translate to challenges that show up in the clinical room. Simple enough as far as that goes, but this slide kind of represents the overview of the three motivating aims, and I'll describe each one of them in a little more detail in a moment. But the main point of this slide being the bottom gray boxes, where you see that somewhere in the center, there's a range of being towards one side or the other, where a certain amount of flexibility, a certain amount of adaptivity is really beneficial and useful. And for a well-adjusted person, it's where they really ride. As you get to the more extremes, then you're going to start to see more maladaptive adjustments, more maladaptive behaviors, and ultimately at the much more stuck range of that than the range of personality disorders that we see. The instruments are able to pick up a wider range than just those that are going to ultimately be diagnosed. And I'll talk a little bit about that when we get there. But this idea basically is that we want to be able to understand and acknowledge where somebody is at, but also help them in being able to really respond more effectively to their world. So to go into a little bit more line by line detail as far as this goes, the theory posits that at the very beginning, at the very outset of life, there is the challenge of existence. If you're translating this to attachment modes, which is one of the things that Robert might touch on a little bit later on, but is very much embedded in the theory, this is associated with the sensory attachment stage. In terms of the evolutionary model, it really speaks to the idea of existence, and that is, will this person, will this individual, will this organism be able to stay in the world in a live manner by making sure that they remove themselves from those things that might end their existence? That's a life-sustaining strategy, or a pain avoidance strategy. Or will they try to get as much out of life as possible? And that's the pleasure or life-enhancing sort of strategy. That's at a very basic level, and where a person falls towards one direction or another speaks a lot to what their general energy is and how it is that they are able to thrive in the world. And I've found over clinical practice, it really relates very closely to emotional energy. So once we have an organism that is surviving in the world, they somehow have to interact. We need to adapt. We need to be able to utilize what's in their environment, both other individuals as well as the environment itself and what the environment presents. And how does a person do that? Do they go into an environment and find an environment that is suitable enough for them? And if anything is done, it's going to be a change to themselves. That's more of an accommodating or passive strategy. Or do they make that environment what they want it to be, or more active or modifying strategy? And again, to relate this as well to some elements of attachment theory, this is associated with sensory motor or autonomy, or really starting to be able to make your way in the world, going from just being nurtured and just surviving to the idea of, I have to live in this environment. Finally, in this basic model, we have replication that is associated with the pubertal gender identity aspects of attachment, and relates to how it is that one organism who is not going to live forever is going to be able to assure that those organisms like themselves are going to continue. either in a self or an other-oriented manner. In the natural world, in evolutionary biology, we often relate this to the idea of the R strategy versus the K strategy. R strategy being typified by oysters or other shellfish that produce millions of offspring over the course of a lifetime and parent none of them. And enough will survive so that the species will continue. So there's really no nurturance in that whatsoever. That's more of a self or independent kind of strategy versus on the other end of the continuum, mammals who have a much more limited number of offspring and have various parenting styles that assure that their offspring are going to be viable and are going to be able to make it in the world. And that's the other oriented. Now, at this point, I want to take a pause and just say, when you're working with one of the instruments, or whether you're considering how a person and their world might be a bit might be constructed, we are saying that different combinations of these patterns are going to produce different prototypes. And then the mixture of different prototypes, or the scales on the instruments, are going to give you something of a picture of how this person is. A couple more details with this, and then we're going to move on. We have what we call motivational dynamics, or in the attachment world, intracortical integration. In Milan's theory, there's actually a fourth polarity. It's not really set up as a polarity, but a fourth dimension, which is abstraction. Relates to how it is that a person is organized within some of these basic motivations. In a lot of ways, this relates to cognition versus affect, but what we're going to talk about here very briefly, just so you know, when we're looking at various personality configurations, we're looking primarily at, in the lower box, we see polarity orientation, whether a person is very strongly adhered to one side, or average on that side, or weak, not really oriented to that, to one side or another. That's represented by different colors. And then there's also a dynamic, and in most cases, most of the personality patterns are what we would call regulated. There's not really a dynamic between the passive versus the active, at least in the prototype. Some are conflicted in one or another places. The compulsive comes to mind, where there's a self-other conflict, that their motivations towards what they want to do and how they want to do that socially and how they want to represent themselves has a fairly strong conflict. For the borderline, it's all three of the polarities. A reversal related to the sadistic and masochistic, I'm sorry, that's the sadistic and masochistic styles on the existence polarity, where the pain dimension becomes something that gets reversed, and that those things that most consider to be painful or life distracting or not, or those things that are a threat to existence get reversed and are sought out in various directions. In some of the more dysregulated personalities, we also have a quality of wavering within the schizotypal, where that is sort of a loss of direction, a loss of motivation, and kind of a wandering quality between these different kinds of motivations. And for the paranoid, an immovable, and that also covers all of them, in which wherever a person may stand in terms of their position in a particular polarity, it really is very rigid and very much very difficult to be able to introduce an alternative strategy, an alternative viewpoint, whatever there might be. So we also want to acknowledge, and we'll do this rather briefly here as well, that it takes quite a bit of rigidity or non-adaptivity or whatever the quality might be to really be able to say this is a personality disorder. So you see those on the further right side for the most part of this slide, where you see our common either diagnostic criteria or prototypes from the model represented in the boldface. And down towards the bottom, we have schizotypal, borderline, and paranoid. You notice that that's moved over one spot, mainly because these are what we call the more structurally compromised personalities. Those don't tend to have what we would call normal style range. On the MCMI-4, that would be a base rate of 60 to 74, what we would call generally adaptive, but we know and we can predict to some degree what sorts of qualities, what sorts of behaviors might show up that might become problematic, but mostly describe the person. For the last three, those are more problematic and really more so are characterized like those in the abnormal type for most of the personalities. And then likewise, on the further end, the clinical disorder, there are the much less functional styles of schizotypal, borderline, and paranoid, and those are described in different terms that actually come from the literature from, I would say, that those were common literature terms for personality styles up to the 1960s or so, which Dr. Millon has used again to be able to describe that range. For a moment, I wanted to just mention, Dr. Tringone mentioned that there are 11 personality patterns on the Mackey-2, and there are 15 on the MCMI, which is the representation of all the different patterns. And this, I'm going to just kind of, you'll have this in your handouts to be able to relate the two instruments to one another. All the instruments relate, and all of these prototypes are related in some ways. Some are not yet identified within the younger populations. That's why, for right now, what we've found is not a melancholic representation. It's better represented in other ways. I'll leave that to the latter part of the presentation. Also, turbulent, schizotypal, and paranoid are not represented on the Mackey-2. But what you see on the far right here are different terms that represent emerging personality patterns. We're not diagnosing a personality disorder in the adolescent range. What we're doing is saying these are some precursors. We're starting to see signs, and we're starting to see an emerging kind of a personality that may at a later point become one that we may look at from the adult lens. And again, we'll leave it at that for right now. And briefly, again, going to go through these relatively quickly here. The idea that much like those of you who have used the MMPI-2, not so much the later instruments, but the original configuration of those, we had these code types. And the Millon instruments work in much the same way, though they're theory-based, that the majority of cases are going to be combinatorial. So it's rare that you'll see just an antisocial elevation, or just, I'm going to use the ones that will show up in the next slide, just a masochistic or just an avoidant, for example. When you combine them, you get a very different sort of a person, and you have to start to look at, okay, what's the real combination of evolutionary polarity motivations that's underneath. So that example, this is actually one that I use a lot in training, and it's based on a very early client of mine who actually had these elevations. And I won't go into all the details of who this person was, but you can imagine what seemed to be the most prominent, but not strongly prominent, was the antisocial kind of characteristics that you might imagine, and put that in your mind in terms of how you feel that might appear. Very oriented towards getting whatever they want to get without really concern for anybody else or themselves. And it was very much a self-active sort of a strategy in that way. This person also had a very high elevation on the masochistic scale, but you think about it, that's almost the opposite in certain ways. And we have a passive orientation and a reversal, an inclination to say that I don't really deserve anything good in life. So if you have this very strong desire and need to get whatever you can get, and you have this horrible guilt at the same time, how's that going to play out? To preface what we're going to get to later, how does that play out in terms of depression? And then to add to that, not quite as high of an elevation, but still significant, there was avoidant. And this started to relate to what their experience of people were like, and how it was that they really felt about how threatening others could really feel to them. Now, that's not your typical picture of what an antisocial personality is, but you start to get all those elements together, you get a much fuller picture. Finally, in this section, we're going to talk a little bit about beyond the motivating aims, beyond those polarities and how that all plays out, there's other specifiers. And that has to do with the functional and structural domains. Under each of the personality prototypes, there is a structure of, generally speaking, 3 or so very strong personality domains. It might be in the behavioral, phenomenological, intrapsychic, or biophysical domains out of a possible 8. But somehow those 8 are going to be represented within that personality. And they are comparable across all of the personalities. So you see along the left-hand vertical that we have all the spectra, and those are abbreviations that we now use and can be printed in the MCMI that represent schizoid, avoidant, melancholic, and so on. And across the top, we have those different domains. Highlighted there are the facet scales. So there is a function within the MCMI, if you're not familiar with it, to be able to produce facet scales that are based roughly on what the theory predicts will be the most prominent of each of those major personality prototypes. And this way you can also begin to compare and contrast and really get more of a detailed picture of who this person is. So for example, with that last example I mentioned briefly, if we have an antisocial personality and a masochistic personality, those elevations showing up, you might look at that and say that under interpersonal conduct, antisocial shows an irresponsibleness, but there's an undeservingness in self-image. And how does that configure itself and play out in a different sort of a way? All of this is leading up to that question of, okay, well, we have this description of who the person is. We want to now take a look at, they're coming into our office and they are presenting with signs of depression. And we want to start to be able to help them out in the best way possible. And we have our standard ways of looking at depression. And what do we do with this kind of information beneath that? If we've done an assessment or we've identified certain kinds of patterns within the personality, how does that help us out in terms of what are we going to do with this particular individual? So we'll have a couple of cases presented, but I'm going to pass this along to Dr. Tringone again, and we'll talk a bit about some of the links between personality and what we used to call Axis 1, or our clinical symptomology, and take it from there. So over to you.
All right, I'm ready to go.
Okay.
Okay, so let's start here. And I would say that when I made reference to Dr. Milan's disorders of personality 3, or DP3, and how it could be summer reading for you, there are 1,008 pages of text. So get started, and you might be able to finish by the end of the summer. Among the 1,000+ pages, though, I did find these 2 quotes in particular that really highlight what Seth and I are trying to talk about today. It is our contention that a full understanding of Axis 1 clinical syndromes require the study of Axis 2 personalities. And complex clinical syndromes are usually an outgrowth of deeply rooted sensitivities and coping strategies. Although Axis 1 clinical syndromes often co-vary and are frequently interchangeable, we could expect some measure of symptom dominance and durability among different Axis 2 personalities, and differences in lifelong vulnerabilities and coping habits should lead us to anticipate that certain personalities would be more inclined to exhibit certain symptoms than others. So if we move to the next slide, what we will have here, for the sake of time, because I will get back to this, but these are the 3 categories in terms of modifying the polarities, addressing the self-perpetuating tendencies, and the clinical traits with domain-oriented techniques. We'll keep going. Okay, so let's look at the personality depression link and assessing a client's personality type when the client presents with depressive symptoms, and we would be able to derive valuable clinical information. For example, What life event may have precipitated the episode for this particular person? Was it a sense of loss of a relationship, death, divorce of parents, since I work more with children and adolescents? Did something happen in which the person has developed some sense of shame or embarrassment? On the other hand, is it that they had something that they were really trying to accomplish? For all of those students who are looking to go to their number one choice college, and not everybody gets to go to their number one choice college. So sometimes there's a sense of they have fallen short of what they set out to accomplish. Sometimes there can be life events, and of course, for certain personality types, there may not be life events that are specifically identifiable and sort of create that watershed of from that event forward, that's when the depression was evident. But certain personality types are inclined to deal with depressive symptoms more, in which then we may see someone with a deep sense of sadness or apathy, withdrawal, or loss of interest in life, whereas some who are feeling depressed might be uh, exhibiting irritability and maybe poor self-control and tend to lash out at others, either verbally or physically. What course of the depressive episode may look like? How about that we could look at an acute episode followed by a quick turnaround? Or might the depressive episode take on a more protracted course? The ability to predict these things really resides in who is the person who is dealing with the depressive episode. What change or development might shorten the episode? Is that change self-generated? Or is it something that actually changes in the environment? So that we look at personality types and which way may be more likely to lead to a resolution or at least a diminishing of the depressive symptoms. And what complicating factors could prolong the episode? And that could have to do with what type of history they have, what supports do they have, what amount of control do we have over certain factors, and what do we not have control over? All of those could be understood better beyond just this is a person presenting with depressive symptoms by understanding all of these factors and who it actually is that we are looking at. Let's keep moving, Scott. Seth? Okay. And for the sake of time, I am going to present two different cases for you very quickly. They highlight the differences between personality types and the presentations when they are distressed. And I want to emphasize the importance of looking at what's going on with a person in their present life, as well as understanding the context of their life, in addition to looking toward what's ahead. In the work that I do with children and adolescents, I really keep a close eye on life transitions. So for the MPACI for 9 to 12-year-olds, it may be going from elementary school to middle school. For adolescents, 13 to 18 for the MACI-2, it can be transitioning from middle school to high school. And then, of course, I just mentioned from high school to college. What'll happen is for the two cases that I want you to take a look at, and there will be two profiles that we're going to look at. Each of them will have as their highest personality pattern scale the dependent or submissive pattern. And then also that they will essentially have an equal score on the depressive affect scale from the clinical syndrome section of the MACI-2. What we want to do, though, is keep an eye on what is the second highest personality pattern scale, and then either related theoretically or to understand that the instrument goes through different phases of development. There's an internal structural level in terms of how the scales actually correlate with one another. So Seth will go through this scale 3, scale 4. In combination with scale 3, we're going to have a submissive traumatizing pattern. And next one, this is the inhibited pattern, scale 2, related to the emerging avoidant pattern. We will have to skip in terms of all of the polarities there. And let's move forward. And I've asked Seth to move us to case 340. Now, this may or may not be the exact one that you have in your handouts, but please keep an eye on that this is case 340, who is a 17-year-old who characteristically relates to others in an affable and gregarious manner. She is skilled at developing and maintaining positive relationships and fits in well with her peers. Her outgoing features cover significant dependency needs because these submissive and dramatizing scales represent the other-oriented, imbalanced personality patterns of passive and active variants, respectively, submissive and dramatizing. What ends up happening is that she attempts to satisfy these significant dependency needs through her persistent seeking of attention, affection, and security through her connections to others. For this personality type, there would typically be an underlying fear of abandonment. And what happens is that this personality type would ward off the possibility of abandonment by essentially collecting numerous friendships, although often through more charming and superficial interactions. This personality type tends to have proclivity toward collecting, accumulating, focusing on the quantity of friendships, potentially not necessarily the quality or the depth of the friendships. On the positive side, this is someone who'll be well attuned to those around her, their needs, wants, and desires, which potentially interferes with developing a true identity apart from them. This is one of the things that could be a self-perpetuating tendency. If somebody overemphasizes, I need to align myself during these developmental years with someone else's views, values, beliefs, and so forth. What ends up happening here is that there's a vulnerability to loss, rejection, or disapproval, which you could note that the third highest scale among the personality pattern scales is the conforming scale. So they are particularly susceptible to adults, people that they look up to, expressing disapproval of them or their efforts or something like that. And what we have here of what would trigger somebody who relates well to others, has a sense of how to get along with others, has a typically positive and large social network. The issue is that a recent breakup has created a spiral into depression. And what would that look like in this particular personality type? So submissive dramatizing types will characteristically overplay their feelings and express them through dramatic and eye-catching ways. You could anticipate that there'd be frequent shifts in moods, sometimes seeming to be able to compose herself, at other times crying inconsolably. There could also be a mixture of anger and frustration, as well as guilt and self-deprecation. Behaviorally, this pattern would be more common to be seen with a sense of agitated restlessness, signs of tension, difficulty sitting still with poor concentration and focus. There could be frequent somatic complaints also in the form of vague aches and pains. Now, those manifestations are essentially extensions of the basic personality style of soliciting attention, reassurance, and support. This type, because you do see the suicidal tendency scale has a relative elevation, could engage in an impulsive episode of self-harm or even a suicide attempt. We'll quickly go to the next slide, Seth. When you have the personality prototype scales with the Mackey 2, you have 3 facet scales per personality prototype scale, and then they would be listed according and visually graphed for you according to the 3 highest. These are not base rate scores, these are percentile ranks. Anything that is within 75th percentile rank and higher is an interpretable range. The importance of the facet scales is that it guides you to those clinical domains that Seth and I have been talking about. For the sake of time, though, I'm just going to say it's there, and we want to quickly move on to a different case that illustrates when you have a second high point scale that the descriptions, the histories, the overall profiles actually change. And while we maintain that the depressive affect scale is elevated essentially at the same level, now we're looking at someone who is submissive and inhibited. So we have the passive type oriented to other, and now we have the inhibited formulated as an active detached type of personality type. And what you have here is that the inhibited type also has underlying dependency needs. The trouble is that those underlying dependency needs have not been met on a consistent basis by significant others in their lives. And what has happened is that they have retreated. They potentially set up a shell for themselves, a protective shell, in which they, instead of engaging and reaching out to others, they tend to be very selective in how many people they will allow themselves to get close to, because history has told them that it could lead to rejection, it could lead to shame or embarrassment. So what ends up happening is that whether this is originating from parent-child interactions, or it's been something that evidenced itself when school emerged and became part of their life, and therefore it's more based in peer relations, but sometimes it can be both, that there is a sense of trouble connecting with both adults as well as with peers. So this person would prefer to maintain a small social network of trustworthy friends. She would remain shy and apprehensive in her nature, hesitant to branch out. That description, again, relates to the self-perpetuating tendencies. On the short term, the idea of protecting oneself is very helpful so that we don't get further hurt and pained. The trouble is that if it becomes more ingrained and entrenched as a way of living life and dealing with the world around us, during these developmental phases, this person is missing out on the opportunities to rework, to re-experience in different ways what their interactions and connections to others can be. They're going to harbor a fear of abandonment also, but they withdraw in that protective way. For them, distance equates safety. They are not going to have an active support network to access when it comes to how do I deal with how I feel about myself. And as you look in the express concerns area, you can see that there's more difficulty for this person in the peer area. Peer into security much higher and into the prominent range, whereas the family discord scale reads just the cusp of present. Something else to point out here in terms of inhibited types do harbor a considerable amount of anxiety and worry about the future and whether things are going to work out for them or not. And you see a co-elevation more here for the depressive affect and anxious feeling scales. In terms of the instrument, I want to point out that these two constructs are totally separate from one another. They actually do not share any items. A prototype item being written and targeted for a depressive affect scale is not on a subsidiary level on the anxious feelings scale, and vice versa. The trouble for this individual is that they do not feel good about themselves. You can see identity and diffusion and self-devaluation are also in the presence levels, and it maintains that it is a challenge for them to access the support either from without and outside of them or from within themselves. And Seth, we're going to quickly go on so then I can hand things back to you. These would be the facet scales, once again, targeting what particular domains we may look for in that submissive area that we have to work on. They do not have a sense of competence about themselves. In the aggrieved area, we have that there is a temperamental component of feeling dysphoric and down about themselves, potentially almost a double depression, that the depressive affect scale picks up things that are more acute, and something like the aggrieved or inhibited scales can pick up something that is more protracted and long-term. I'll quickly keep going so that I want to say that each of these personality types then, if it was a prototype, would have these particular goals. And what we have here is to balance the polarities. I want to focus on the counter the perpetuations. That's less abstract for us. It's more specific rather than globally dealing with the polarities. And each part here, the self-deprecation, we would want to help this person identify strengths and competencies. There's an avoidance of autonomous activities by the submissive type. They really tend to over-rely on others. So developmentally, we want them to embrace growth opportunities. And rather than clinging and putting so many eggs in one basket, we would like them to begin to engage in autonomous activities. Now, I'm going on fast forward, so I give Seth some time. I would say that, of course, we want to address the depressive symptoms first in order to relieve the sense of distress that this individual or these individuals may be experiencing. We want to make sure that they understand that for the age range that I work with, I'm typically looking at what their strengths are. Seth had something on one of the slides in terms of things are along a continuum in terms of what is adaptive. And what we want to do is look for greater balance within the polarities. We want to enhance someone's flexibility, adaptability, and build the skills that they'll need in order to deal with whatever life circumstances they're going to face. And we want to create a sense of resiliency from learning from their experiences, embracing the world, going out there, gaining insights into how they can respond to situations in more effective ways. And Seth will just quickly go through the next two, and then I hand it to you. Counter perpetuations among the dramatizing type, I alluded to this, that they need to reduce some of that external preoccupation as to what other people want from them or need from them. We want them to enhance their sense of self-awareness, self-sufficiency. Superficial social relationships, let's help them to establish genuine connections. And if you looked at the modalities, what we would look for in the behaviors that they engage in, learning cause and effect relationships. Also, in terms of cognitive style, help them to develop more self-reflection, work with them to elicit their own opinions so that they can begin to formulate what their thoughts are rather than that their thoughts are supposed to mirror what they think others are thinking they should think. And finally, on the inhibited type, that we want to gradually expand their social connections rather than allow that active social detachment to continue. We want them to be able to see the world in a different lens rather than being so hyper aware and hypersensitive to harm that is out there. Of course, we would have to pick very safe objects for them and to really work on some of the perceptions that they have, the ways that people interpret things, and then finally the actions that they take. If we misperceive, it's going to be hard for us to act in an appropriate way. We may perceive something accurately, but if we misinterpret it, it's also going to lead to problematic interactions with others. All three, perception, interpretation, and action, have to fall in line with each other for someone to live in the world in an adaptive and healthy way. Back to you, Seth.
Okay. Thank you, Robert. And in the interest of time, I'm going to just spend a few minutes with a case. I'm going to just give very short shrift to this particular slide, which speaks to the idea that there are a lot of cues that you can get from the theoretical information and in your own way, develop your own language to be able to enhance the therapeutic alliance. I've kind of come across a way of doing this for me that works quite well, that begins with looking at each one of the polarities on its own and looking at, for example, with an avoidant, you have that active pain orientation. And it's not going to do somebody much good to say, well, you have an active pain orientation. You want to see what that's really saying. It seems crucial to you to make sure that you fly under the radar. There must be a lot of mental energy that you're seeing, and you're taking some of the cues from them and what they've already shared with you, and then begin to blend that with other elevations that you're seeing so that you ultimately help them come into a place of understanding the different elements that make up them and how that might play out in terms of what they're dealing with. So that being said, again, I only want to take a couple minutes because I do see we have a couple questions in the Q&A that we want to get to. I'm going to cherry pick a few elements of this is actually about 2 years ago, I did this therapeutic assessment. And those of you not familiar with that model, it essentially is a semi-structured way of doing a full battery assessment where you choose instruments based on what the presentations are, set up a series of questions, and ultimately help them answer their own questions in a collaborative way, trying to help them come up with their own answers through what you see in the tests and what they discover about themselves. So Bradley, not his real name, initially I was contacted by his father, and that becomes important for a little bit of context, because what I would say about his father and his mother, two very opposite people that were interested in helping Bradley, I would say, to a fault. This is somebody who's coming back from an incomplete semester in college and really has, in a lot of ways, failed to launch. And his father made several calls to me each time saying, you know, I want you to assess for depression and anxiety and loneliness and social introversion, possible ADHD, LD, you get the idea. A lot of different things. But really, he just needs to get out of his own way. And then I met this kid. And it was pretty apparent that he was stuck in a pretty bad depression. And as we went along, he didn't really like the softer explanations that mental health issues like depression spoke to. He was leaning towards, and his father was leaning towards, trying to get him an ADHD diagnosis, because I didn't get the sense it was for stimulus med seeking or anything like that, but because it had a hard and fast answer. And, you know, if you have this and you have a treatment, then you know what you're going to do. Whereas depression is going to be a bit more involved. So we tried to get him involved in this therapeutic assessment, and he went along quite well, though at times he called himself out as being somewhat stubborn. And just look at a couple of elements of his MCMI. I'm going to forego, I don't have the other testing information here anyway, but I'm going to forego commentary on some of the others just to show you that what we're looking at here is a fairly classic on the lower third or so of the MCMI profile page. Pretty clear double depression with some anxious characteristics, a little bit of internalization in terms of somatic symptomology, not something that he was actively complaining about, but acknowledged on the instrument. But really, you know, in that sort of very classic way of like major depression being more of a pneumonia, persistent depression being more like having asthma, he was in the throes of both of them and didn't really want to acknowledge that. Again, as we went through this, it was really more about, let me find a more hard and fast answer. I don't really totally accept this idea. Neither did his dad. Mom was a pile of mush, and she was like, he's depressed. You really have to work with this. And both of them were far too involved in the assessment. Always something I was trying to manage. That becomes important in this overall presentation as well. Here he gave me a good amount of information, and not surprisingly was not particularly positive about the way that he presented himself. And something I also like to look at before I get into the personality scales are the noteworthy responses. And he listed quite a few, and a lot of them are very depression oriented. Something I want to quickly point out is that there are quite a few self-destructive and vengefully prone items that were endorsed. But they are two different kinds of qualities across both of those categories. Some are shared with some of the depression scales, and others are written very specifically for those qualities, like self-destructiveness or somebody who has vengeance. And he didn't acknowledge any that were specifically written for that. Something that he did acknowledge that I thought was the most important out of this was the alienation that he felt. So I'm concerned the people I depend on will leave me. I take great care to keep my life private so no one can take advantage of me. These were all impediments to trying to get him to be a little bit more forthright about his concerns. He didn't want to let anybody down and really feared what might happen if he did. So the easiest way forward was really the way that he wanted to get to. This is a pretty complicated set of personality scales, and we could go into a lot of detail here. I'm going to include a little bit about both borderline and paranoid had a minor elevation just into the concerning range, but not clinical, speaking to the fragility that he was experiencing. The center point, though, I think was really in the first three scales, the main one being melancholic, but also avoidant and schizoid kind of characteristics. I'll get a little bit more into just how they look all together. But I also want to point out some dependency, but also a little bit of that independent that would come up from an antisocial presentation. You can see where he's really trying to struggle and he's lost. And when you get a profile like this, I think it's a very tread carefully sort of a situation. Skip over those. I did say that's sort of representative fragility, and you can kind of understand where that is. Those are more, I consider those three scales, if they're not the most prominent, sort of the filter scales, if you're thinking of it like a camera. You have a subject and you have sort of a filter, you say sepia tone or something like that. Those three scales work in that way. These are the four that were most prominent, and they were relatively close together, but melancholic sort of stood out as the one that was kind of driving most of the difficulties. Aligned again with the major and the persistent depressive scales, but really coming into the characterology of it. He learned to look at the world from a young age from this kind of defeated lens. Passive pain orientation relates to the idea of giving up or giving in and saying the world is going to do what it's going to do to me and I'm just going to let it. Also thinking about his family situation, it really kind of built into that as well. So you can kind of begin to really understand that combined with one active scale, that's the avoidant, of trying to do something for himself and keeping his guard up, but mostly giving up and also kind of saying, you know, these bad things that are happening to me, I'm kind of getting something out of it in that masochistic sort of form. How then, I'm going to skip the facet scales for this, do we get to, and I'm going to leave this more as a hypothetical and move into our Q&A, but think about from the little bits that I've brought up, and I wish we had a little more time to kind of get into the nitty gritty of it, but how does that change what you would do with somebody presenting in that context, in that situation with what we would call a double depression? So with that, we have a minute or two, and I think we can go a little bit further than that for those who can stick around, but I'm going to call to Scott Pawson to begin our area of Q&A for our presentation today. Scott?
Thank you very much, Seth, and thank you, Robert. Very, very informative session. We have three questions that I think we can try to touch on. I'll do the quicker ones first, I suppose, although I'm not sure which is quicker, but we have one question from Dante. Do you consider overall cognitive ability in understanding teen and young adult presentation? Probably directed to you, Robert.
Hi, Dante, first of all. Of course, we would consider that because it's important to understand what the expectations may be. For example, if I'm thinking about someone who's 17 years old and transitioning to college, and the family wants them to go to a very prestigious school with name recognition and so forth, but they're really not up to that caliber, that's not going to be a good match for them. Or you can scale that back. So there's no doubt that we would take cognitive ability into account, and across the board too, not just in terms of IQ per se, but also in terms of executive functions. That would be very important in terms of how somebody manages life. So while we're able to present a couple of cases, illustrative cases, and the instruments can do some good work, I would typically not want them to just stand on their own, that it is good to have some other measures to create more of a context.
Let me just add to that quickly. The case that I just presented, the major question that came up was, do I have ADHD? And then that started to be something that they kind of wanted to be the answer to the question as far as that goes. And it was on the border. But I think the bigger question was there were a lot of expectations thinking that this young adult was gifted, but had never had that testing, and did extremely well in high school, but didn't do so well in college. And a really brief sort of IQ measure kind of indicated to me that he was average and maybe touching on above average in a couple of areas, and that was it. So the expectations of that become extremely important too.
Thank you, Dr. Grossman. Seth, this one may or may not be quick, but how does one connect these personality insights into traditional therapies like CBT?
Great question. There is a quick answer to that, and there's a much more elaborate one. We'll only be able to get to the quick, and that is that within the instruments and again within the theory, there are all those domains. and that the descriptors of the domains, which we kind of glossed over today, give you a lot of insight in terms of, like, for example, CBT. What is their cognitive set? What's their style like? There's a lot of descriptions within that that you might be able to identify from the facet scales, as well as using that big chart without the facet scales or beyond the facet scales to say, here are some of your targets for these more specific therapies. And there are cognitive therapies involved, interpersonal, more psychodynamic, as more constitutional, I would call it, but that's mood temperament, that's the physical body, and what you might do as far as what happens there.
Great. Thank you, Seth. This last one, I think you could probably talk about for quite a while, but let's go with, do you at times have to rely more on your perception of and intuition about the person you're working with rather than on the results of an instrument filled by such a client? Further, are you often surprised by how your perception is different from the self-reported? Thank you.
There'll be plenty of instances of that, and I do believe that there were studies done, maybe with the MCMI-1, not known as the 1, but with the MCMI, and maybe the MCMI-2 as well, in terms of how accurate clinicians thought the profiles and interpretive reports were. So to me, I would try to have a discussion with the person regarding how it is that this is how they have presented to themselves. This is what they recognize about themselves. I use an idea for myself of referring it to thresholds and filters. That the idea of thresholds is, what is it, how does one define often or very often or something along those lines? What is the threshold that leads them to endorse true to one of our self-report items versus false? And then the idea of filtering, depending on the context of where this evaluation is taking place, whether the person wants to participate in treatment or not, and so forth. There are all different types of motivations for which somebody comes to us and we have to account for. So therefore, they may filter some things. In particular, I look for areas around impulse control and anger to see if they are not endorsing those types of items, but there's a history by report of some of these types of episodes. But frequently enough, we have to do some rectifying, and we can usually figure it out along the way. In regard to the instruments themselves, we do have different ways of looking at how open somebody was in their report. Seth presented the disclosure, debasement, desirability scales. Somebody may be engaging in impression management. With the Mackey 2, we go about things in a different way in terms of what's called response negativity. A high score there would indicate that somebody was endorsing a lot of negative things about themselves, and then did not endorse some of the more positive items that they could have about themselves. So not focusing on the good, emphasizing perhaps more of the bad. Sorry to use that type of a dichotomy, but you can have an elevation there that we need to sort through. Is it related to their background and experience? Is it impression management? We try and figure that out as clinicians. But good question.
Indeed, pretty thorough too. And I would only add that thinking about it in a multi-method sort of a way, whether that's your clinical interview and the test, or whether it's different types of tests that, more performance-based tests or projectives, as we used to call them, get at things by getting around certain defenses in a different way than a self-report will. So you get different information from both. And usually the truth is between all these sources, and that's our job, to really be able to use that intuition as well as the hard data and come up with the best picture that we possibly can.
Right.
Very good. Well, thank you, Dr. Grossman, Dr. Tringone. Those were the questions that we had. And we had a thank you from one of our questioners for your response.
Nice.
Very good, everyone. Thank you very much for joining us. Thank you for attending, and we hope to see you again soon on another Milan-related webinar. Everyone have a great day and have a good weekend.
Thank you for listening.
Thank you all. Have a great weekend.